When I was a student in training in Massachusetts General Hospital, it was viewed as one of the most technically, scientifically sophisticated institutions in the world. And leadership there, the general director and the chief of medicine, decided that they were not going to compete to do the first heart transplant. This was in the early 1960s. When that transplant was done for the first time in South Africa, not to very much benefit for the patient, it was the same year, 1967, that the MGH opened a community-oriented primary care center in the Irish immigrant community just north of Powell Street. And my mentors there recognized the importance of understanding cultural context and cultural intelligence, as well as emotional and social intelligence in addressing both decision quality at the micro level and at the macro level. What does this person need? Is it medical, or is it emotional? Is it social support? And at the macro level, how do we engage the schools so that we're dealing with one of the segments, the chapter 2, parents and children? How do we engage others in the community? So, I am incredibly grateful for having, arrived at Harvard when they were announcing a new PhD program in public policy, and when the MGH was announcing a new training program that had me learning not only from the best consultants, some of the best consultants in the country, but also from advanced practice nurses who led our outpatient rounds 4 days a week. And on Friday, outpatient rounds were led by a social worker. Mm. So there's that background.
Yeah.
And we're working here with the vanguards. I recognized how unusual my experience. I started writing the first textbook of primary care at a time when I was still training, and it was published when I was attending in the intensive treatment unit. So being able to talk to people in the acute trusts, and in Middlesbrough, for instance, about decision quality in A&E, and in primary care, is something that has opened doors to helping them see that the people they're accountable to don't understand complexity of decision-making at the front lines. They're focused on system functions of primary care, access, most importantly, because a problem with access is visible to patients who are voters. They're not aware of the complexity of medical diagnosis and treatment, psychological diagnosis and treatment. We've already talked about how those are intertwined. Supportive patients from all backgrounds and all phases of illness. Treatment decisions, explaining prognosis. All of those things are really very complex. And they all involve learning from variation in order to avoid underuse in the neighborhood, making prevention impossible often, or overuse in the neighborhood, causing clinical cascades that lead right through A&E into the hospital and ITUs.